Hey, Dr. Ratcliffe here. It's Sunday night, and this video is about dry needling. Everything you needed to know about dry needling. Okay, what is dry needling? Dry needling is a technique using an acupuncture needle to treat soft tissue pain and dysfunction. What is soft tissue? Soft tissue is everything but bone. So it would be the muscle, the tendon, and the fascia. I often use an example when talking about fascia. Fascia is very important. It can cause a lot of pain, whether it's chronic back pain, neck pain, headaches, or elbow pain. Fascia is like, well, if you've ever skinned a deer, then you know what fascia is. When you take the skin off, it's that thick lattice that attaches the skin to the underlying connective tissue, and it's very difficult to get off. It actually has a tensile strength stronger than steel. It is tough stuff, and that can get scarred and have some dysfunction, and you can experience lots of issues from tight fascia. So it also treats what are called trigger points. Trigger points are an area in the body that have is an area of the muscle that is neurologically active, and oftentimes there's pain in the trigger point and hypoxia, so lack of blood flow. Those muscles contract so hard that the little area gets less blood flow and it becomes very painful. And you know you've got a trigger point if when you push on the tight muscle, it refers somewhere. The classic one is when your mom squeezes you on that shoulder and it radiates up the back of your head. That's a trigger point. It's called a latent trigger point. An active trigger point is when you have referred pain because of a trigger point. Oftentimes I'll have people who think they have sciatica, but instead which is from like a herniated disc, but instead they'll have an active trigger point in the piriformis that is in a similar distribution down the leg, and it's a myofascial trigger point versus a herniated disc. So it's a technique to treat soft tissues. Let's see. The technique was kind of the first guy that ever experimented with injecting needles was in the 1930s, and his name was Dr. Kellgren. This was a guy, as a medical physician, who started injecting people with things. Actually, this was in England. Various substances to try to get better results for people who were having a lot of pain and disability due to some, just any kind of pain syndrome. So Dr. Kellgren in England was really the first person to start doing any kind of injectable type of therapy. It really wasn't until the 70s when our relationship with China expanded, and Mao kind of opened the country up, and the Western physicians here in the United States started learning about acupuncture. And there was a number of doctors. What was his name? Dr. C. Chen Gun in the 70s started doing a lot of work based upon Chinese acupuncture. And then it wasn't until Dr. Janet Travell, who was President Kennedy's physician, really popularized and went the extra mile with her research into trigger point and myofascial pain syndromes. Now, what's interesting is during that trigger point, during that whole myofascial pain syndrome and sticking needles in people and learning from the acupuncturists, Western physicians started doing a lot of experimentation and really using our own methods. In Western medicine, orthopedics, our understanding of anatomy, we've really kind of developed our own system here in the West versus in the East. That would be acupuncture. So acupuncture would rely more upon their philosophy of where they put the needle and why they do it, based upon the acupuncture treatment points and the meridians and all those other things, whereas Western medicine doesn't necessarily subscribe to some of those things and would do it more in an orthopedic fashion. So it's the same tool, but different philosophy. We both use acupuncture needles. Now, what's the difference what are the differences in needles? Well, an acupuncture needle or dry needle is a solid, very thin needle, kind of like a hair, and you really don't feel it very much when it goes in. And if it's trigger point, you'll feel it, but you really don't feel much. It doesn't leave a lot of trauma to the surrounding soft tissues. Versus a regular needle, like if a orthopedic surgeon gives you a cortisone shot, that's a thicker needle and that's hollow and it's injecting something, either like a lidocaine or a steroid, which can be, those medications can actually be cause some, there's side effects of those medications and some things that you might not want to do. For example, if you get a cortisone shot in your elbow, research is showing, hey, it might help temporarily, but in the long term, you're going to have more problems. So we stay away from that. It used to be the go-to treatment 10 years ago, but now we kind of stay away from recommending cortisone shots in the elbow. Then comes dry needling. We can do dry needling every day if we want to. We can only have a few cortisone shots per year. So dry needling is great for that. Who will benefit from dry needling? Acute patients. So patients who walk into the office and are in a lot of discomfort, they often benefit very greatly from dry needling. We'll have a patient who sometimes needs to be carried in, and we'll do the classic chiropractic treatments, the physical therapy stuff, the ultrasound, the electric stim, the traction exercises, all that stuff, the stretching, the massage, and they'll get good results. But when we add when we add dry needling, they get results quicker. We find they're able to get out of the acute stage faster. And that's interesting. They get out of the acute stage faster, and sometimes we can get them more into a rehabilitative stage quicker, and they can start doing their active care program and get back into exercising on a quicker than they would if they didn't use dry needling. So acute care patients get it. We commonly use it for patients with back pain, neck pain, headaches, jaw pain, TMJ, rotator cuff disorders, lateral epicondylitis or tennis elbow, wrist pain, arthritis, knee pain, and plantar fasciitis. Those are the conditions that we commonly treat with it. What should we talk about next? I wanted to talk a little bit about a couple of research studies. So take a look at this. Let me find my cursor here. This is a great study. This is a study. It was done by An and June in the BMC Musculoskeletal Disorders Journal. So the title, this is a lot, but it says fluoroscopically guided transforaminal epidural dry needling for lumbar spinal stenosis using a specially designed needle. So what these guys did, so first let's talk about spinal stenosis. Lumbar spinal stenosis is an arthritic condition of the back. So it's when the front part of the spine, called the vertebral body, has degenerative disc disease with some spurring and maybe a disc herniation. And then the back, there's some arthritic changes in the back elements, and oftentimes there's some hypertrophy of the facet joints, which causes arthritis, and then some an overgrown ligament called the ligament of flavum, and that can slowly start to squeeze the area for the nerve roots, and very painful. Patients will have a lot of back pain, but interesting enough, with stenosis, they'll get difficulty like sciatica. It's a special type of sciatica. It'll go down both legs, sometimes one more than the other, but usually you'll get what's called neurogenic claudication. The patient will be able to walk for an X period of time. Let's say they can walk for 10 minutes, and then their legs start to really bother them. Then they have to sit down for a while. Their legs feel better. They can walk for another 10 minutes. Then they have to sit down. That pattern is called neurogenic claudication, and that's a hallmark of lumbar stenosis. It's a very serious condition, often requiring surgery, and it's degenerative, meaning your spine is going to continue to get worse. And so your risk for surgery, it's higher the longer you go on. So it's something that if you have any kind of degenerative changes in the low back, you want to address this as soon as possible before it ever gets to stenosis, and your risk for surgery goes way up in spite of everybody's best efforts. So what they did, they took people with lumbar spinal stenosis. And it says here, 34 patients with lumbar spinal stenosis underwent fluoroscopically guided transforaminal epidural dry needling. So what a fluoroscope is, or fluoroscopy is, it's like a video x-ray. So the patient's laying down and they're shooting this x-ray beam, but it's constant. It's like and they're able to see the needle going in, and they place it right at the level of the stenosis, right next to some arthritic changes in the level of stenosis. And the results were very good. So go down here to results, and it says their Alsostree Disability Index score decreased from 41.4 to 25.5. So a moderate disability to a mild disability. The average pain improvement, VAS, that stands for Visual Analog Scale, that's a pain scale, went from indicated that 41% of people reported good to excellent treatment response, while 32% had good to excellent treatment response on the ASOSTRI. 64.7 had a good to excellent treatment response on the self-rated improvement scale. Anyway, a 40% improvement for lumbar stenosis. That's incredible. That's without medication. It's without surgery. That's with a simple procedure. I can't recommend dry needling enough, especially for arthritic conditions of the spine. It works very well. Very well. Medications oftentimes are used to manage these conditions long term, and it's just not advisable. It's not something you want to have to rely solely upon. So, great study with lumbar epidural spinal stenosis. That was a really important study. Next one we'll look at was, this is an interesting case. This was in the Journal of Physiotherapy and Theory and Practice back in December 2014. This is a case study. So this physical therapist had a patient who was suffering from elbow pain, so pain right here, and were self-treating it. They had what the physical therapist called cyberchondria. So this is a patient who self-treated a little on the obsessive side. The study said they used kinesiology tape, massage, ice, neuromobilization, which is kind of a stretching technique, K-taping, and they were exercising, all of which had a failed outcome. Clinical findings revealed that trigger points in his right brachioradialis muscle, blah, blah, blah. Anyway, later the physical therapist did dry needling and exercises, and the patient was completely pain-free and fully functional at the end of the 6th session, which was maintained at a 1-month follow-up. So, despite the patient's best effort at their own home physical therapy program, they benefited greatly from dry needling. Interesting. Cyberchondria. I actually have never heard that term before, except for this when I read this paper. Okay. Next study. Dry needling and the treatment of post-stroke muscle spasticity. So when you have a stroke, when you have a spinal cord injury or you have a brain injury, so in the central nervous system, we call those upper motor neuron lesions. When the main trunks of the nervous system, so the brain or spinal cord, are damaged, either a cord injury or a brain injury, your muscles are going to get very spastic. Contrary to that, when your muscles are damaged outside the spinal cord or brain, in what we call a peripheral nerve, they'll go weak. So, different. So they're not spastic paresis, they would be flaccid paresis. Muscles would be very soft and not rigid and not contracted. So this was in a stroke clinic. Looks like 2 people. This was published in the Journal of Neurorehabilitation. There's a group out of Iran and a group out of Georgia. And they were working on some people's arms, and they had a significant reduction in the spasticity. So I've used dry needling for my neurodegenerative patients as well. In addition to stroke, I've used it, but also neurodegenerative diseases like Parkinson's disease, or even autoimmune diseases that affect the muscle, like patients with rheumatoid arthritis, lupus, scleroderma, arthritis associated with psoriasis, any kind of inflammatory component. I've also used it on and do get good results with. But this was an interesting post-stroke case, which is a brain injury and causing hypertonicity, and they got good results. So, okay, next one. Use of dry needling. This is in the Journal of Chiropractic Medicine. The use of dry needling in myofascial meridians in a case of plantar fasciitis. Excuse me. If you've ever had a cortisone shot for plantar fasciitis, it's literally the most painful thing on the planet. So in comes dry needling, and it's very effective. We use it for plantar fasciitis all the time, and it is far less painful than a cortisone shot. And what's interesting is the mechanism. The dry needle, first of all, it's called a dry needle because there's nothing in it. It's a solid needle. And when it goes into the trigger point, it breaks up scar tissue, and it brings in blood flow and creates a healing. It triggers a healing response. So it's a very small needle versus an injection uses a larger hollow needle, And when that hollow needle comes in, it causes some damage to the tissue, and it can be very, very painful. And then you have the added pressure of the medicine that's being delivered. And it's not something you do over and over again. Steroid shots, they're done few and far between because it can cause some local bone erosions and some other things. So, but dry needling can be done. So that's one of the reasons why dry needling is not very painful, is because it's a solid needle and it's very small and doesn't cause the trauma that something else would do. A lot of people find it very relaxing too. So plantar fasciitis, very effective treatment for that. Here's one more. Short-term improvement. This is in the International Journal of Rheumatology. Short-term improvement following dry needling stimulation of tender points in fibromyalgia. Fibromyalgia is a chronic condition, and it's responding well to dry needling. And what they did, actually, they did it for 6 weeks. Here we go. In conclusion, patients severely affected by fibromyalgia can obtain short-term improvements following weekly dry needling for 6 weeks. You know what's interesting about fibromyalgia? We'll do dry needling. The patients can't tolerate a whole lot, so dry needling is gentle enough to do and very effective, which is really good because patients with fibromyalgia don't seem to be able to tolerate being heavy-handed. So a heavy-handed massage or physical therapy or chiropractic has to be a light approach. So we're very gentle. Interesting enough, this is a side note, that people with fibromyalgia, lots and lots of new research is coming out that it's due to a LPS, lipopolysaccharide, and sometimes an overgrowth of bacteria in the GI tract that will cause some of the inflammation. And so a lot of people will put on what's called a SIBO diet with fibromyalgia and get excellent results as well. So I hope this was interesting, and if you are considering dry needling, I'd highly recommend it. For our acute patients, meaning patients who need to get relief quickly, usually it's only anywhere from 4 to 10 sessions that will recommend it, and most patients find it very effective and relaxing. For our chronic patients who that are undergoing active pain management, so they've been on opioids for a long time to deal with a chronic pain condition, or they're getting lots of treatment from physiatrists, so they're getting a lot of steroid injections and lidocaine injections and things like that, we will recommend it for usually longer. I'll usually recommend a 6-week program, and they're able to often reduce their need for medications, and especially with the opioid epidemic, that's a really good thing. So that's dry needling, and we'll post some other videos later on with certain techniques that we do. There's a number of different techniques doing it. So sometimes there is a technique we call pistoning, where we'll put the needle in and try to trigger a twitch response, and then we'll take the needle out very quickly. Another technique would be just to put it in the trigger point and leave it for a few minutes, which is very effective too. It's very relaxing. Patients just lay there. A final technique would be to put it in and add some electrical stimulation to it too. So those are different techniques that can be done. Well, I hope you enjoyed this, and if you have any questions, we'd be happy to answer them. Take care.